Hey, welcome to the webinar this evening, Next Generation Cements in Practice. I'm Dr. Joseph Kim. I am going to be your presenter this evening, or morning or afternoon, wherever you may be listening to this presentation from. Just a brief intro to my background. I graduated from the University of Michigan in 2001, the School of Dentistry, that is. Have several fellowships in various academies, memberships, and others as well. In terms of disclosures, the main one is that I am employed by BISCO, who is sponsoring this evening's webinar as a clinical advisor to the Research and Development Department, as well as receiving material and financial support in preparation of this presentation. There's other disclosures that I felt was relevant, as some of the imagery was captured on some of these things, as well as just past financial or material support. All right. Tonight, we're basically going to review the benefits of what I like to term a next generation cement. Now, obviously, some of these, there's no official term called next generation cements. I just figure it's a little easier than numbering each one. And we'll do a little bit of history and see kind of why I have affinity towards this particular phrase. But after tonight, attendees should be able to identify or be aware of multiple benefits of these self-adhesive cements, understand the role of MDP in self-adhesive applications, review the instructions for properly using next-generation resin-based cements, and identify clinical circumstances where self-adhesive cements may be preferred. Keep in mind, some of these statements that I'm about to review with you are, like many things in dentistry, somewhat controversial. So I always advise you, never believe what the speaker says. It's always good to look up references, do your own due diligence. But in the meantime, at least I'll give you my experience and my opinion. So what are these next generation cements? Let's take a look at where we began. First of all, when we say cement, it's kind of confusing because what has happened over the last several decades is kind of a merging of chemistry. Prior to the advent of resin composites, we were using a lot of zinc-based products. I think eugenol kind of was in there somewhere from the Egyptian days in some form or another, all the way to modern times. And people have looked at all sorts of methods of trying to attach wires, but of course that wouldn't count as a cement, but attaching to similar things to existing teeth. So when we talk about cements in terms of restorative dentistry, we're really referring to luting cements or luting agents. And the word lute comes from the, at least according to Merriam-Webster's dictionary, it means to seal or cover something such as a joint or surface with lute. And lute as a noun is that substance such as cement or clay for packing a joint or coating a porous surface to make it impervious to gas or liquid. In dentistry, luting agents or cements join two different things together. In this case, beginning with the Gold Crown days to whether it's acrylic or any number of things to structure, generally speaking. And so we join these with a luting agent or cement, resulting in a mechanical union and sealing of spaces and gaps between these two dissimilar materials. Keep in mind, this terming of generation is somewhat arbitrary, but there was a decent meta-analysis here from Godzi et al. Back in from the Journal of Clinical Experimental Dentistry in 2021, and starts out, well, in the discussion they review, there's a good synopsis of the various types of cements that have been introduced in dentistry. And the first one that we're aware of in modern dentistry is zinc phosphate, developed in the 1800s. And compared to whatever was being used prior to then, It exhibited high elastic modulus, high compressive strength, low film thickness, and of course the downsides, if anyone has ever used zinc phosphate, low pH, very acidic, no adhesion with that acidity. So that's you're getting acidity without any real benefit. In fact, one of the worries or concerns is that low acidity may cause pulpal irritation or even damage. There's no real adhesion to speak of, so it is truly like almost like mortar between bricks. And then weak physical properties in general, and of course, highly soluble. So back in, when I graduated, I don't think we really used zinc phosphate, but I did try it out for a little while as I began my implant restorative journey, because some things about it are somewhat beneficial, especially if you want weak retention. Having no adhesion certainly helps. And of course, we're not dealing with two structures, so the acidity, while there might be some theoretical downsides, really in regards to titanium wasn't that great of an issue, at least with zinc phosphate. Problem I had was sometimes the working time is hard to control. Anyone who's used it, you can control it by refrigerating or even freezing a glass slab, but that gets old real quick and hard to maintain a infection control procedures in any meaningful way. 1968 was the introduction of zinc polycarboxylate. Now, what polycarboxylate cement brought was from acidic, it actually went to a high pH. So it's interesting because years ago, I started using zinc polycarboxylate. I think probably the most popular one is either Shofu's High Bond, or the one we use is Duralon. I think 3M makes Duralon. But regardless, Duralon or zinc polycarboxylate is a very interesting material because we don't use it in a permanent setting, but for provisionalization. I often treat patients who travel in from out of state or are very phobic or have to have a little more reliability with their provisionals due to their job or whatnot. And so we'll rely on not only that, sometimes we find ourselves in situations, I treat a lot of phobic patients. And so a lot of these folks, I might not see them, even though we tell them, yeah, we should see you once, twice a year or more. I might not see them for 5 years at a time. And so often we will do preparations that are subgingival to kind of compensate for the fact that when you do, just for natural resorption, changes in the soft tissue, et cetera, as they age and under function. And so that means that we are often in an environment where I don't want eugenol jam-packed subgingivally. Same with implant restorations. I don't want a bunch of resin modified or anything kind of that is not kind to the soft tissues. And so what we noticed in our practice was the zinc polycarboxylate really did result in some meaningful improvement in soft tissue between appointments, between preparation or final impressions and delivery appointments. The downside is it is a fairly tenacious cement. And so to remove it required some modification of our protocol. But when it comes to like resin, it's wonderful because you remove a temporary with subgingival margins and there is not a whole lot of bleeding or inflammation and subsequent bleeding, I should say, which makes any bonding procedures that much more predictable, less bleeding, etc. But regardless, in 1968, they weren't thinking that far ahead. They were just thinking, wow, we finally have something that kind of sticks to tooth. It's fairly low solubility and fairly high in terms of biocompatibility. The cleanup of this can be a little bit tricky, mainly because it goes through a kind of gooey, or what I call like a gummy phase, where it gets very stringy. And it takes some experience to do an adequate job cleaning it up without causing problems. The next year, we had glass ionomer introduced. In glass ionomer, most of us have used it to some degree or other. is not a bad material. I mean, it's not great, but it's not horrible. In 1969, I can imagine they viewed it with wonder. It must have been amazing because finally you had a material that would actually have some adhesion, not just to tooth, but also to metals and, which was a predominant restorative material for indirect, I should say, for like full coverage crowns, etc., inlays, onlays. It also had some advantage of releasing fluoride, as well as some rechargeability of that function. I think it's been well discussed over the years. The disadvantages are relatively poor physical strength. It's certainly not a very tough material. If you've ever removed it, it can chip away quite easily. And perhaps the part that I didn't like is the relatively high solubility in water or moisture in general, poor wear resistance, and the fact that it's radiolucent. Now, granted, in 2001, when I graduated, that was when things just started going into like a metal-free, all ceramic kind of approach. That's when it was beginning anyway. And so obviously, we were taught shoulders with bevels and whatnot, which would be fine for, glass ionomer is excellent in that circumstance. But the moment you go to chamfers, these rounded kind of preps with a butt margin, it starts to becoming an issue, especially with gap distances greater than 20-30 microns. And that makes sense. You use a toothbrush, those bristles go somewhere, and you can brush away a relatively weak material without too much effort. Any subgingival margins, very, very difficult to keep the glass ionomer from just dissolving even before it sets. And then we have the era of the resin-modified glass ionomers. Now, this I think was a major improvement. In fact, I do believe this was the material that we were using when I was in dental school, and probably the first 5+ years of my practice was. I think the major players here historically were GC through their Fuji line, Fujisem, Fujisem 1, etc., as well as I believe 3M with their Reliance resin modified glass ionomer line, and both performed very well overall. You did have a significant improvement in mechanical properties due to the resin component. However, you still had the same, and lower solubility, of course, but you still had the same kind of moisture sensitivity because until the material set up, it was prone to dissolution. And if you read the actual instructions, it does have pretty clear, I believe it was Fuji's instruction that you had to keep it dry for 14, 15, some pretty unrealistic length of time. And indeed, when we've had crowns, either 10, 15 years later, either debond or more likely removing a tooth, let's say, or some other fracture, it is interesting to see, especially with modern prep designs, meaning a chamfer type or a butt margin type of preparation on an all ceramic restoration. It is interesting, at least in my experience, to see the kind of micro leakage and all the kind of a black scuzz. For the subgingival margins anyway. Supergingival seem to be okay, but obviously fairly unaesthetic in many areas. There was some sort of concern about setting expansion. I personally never experienced that, but especially put it this way, when it had to count, let's say a shorter prep, a bridge abutment. These times, sometimes I would worry if the resin-modified glass ionomer would have enough retentive ability or properties to not cause a headache down the road. Resin cements were being used for some time. They are, I think, was a legitimate generational change. You had not just a chemistry difference, but with the chemistry difference, a massive improvement in mechanical properties. It's just, and in terms of solubility, I would say in an oral environment, they're not soluble at all. The color options that you didn't just have gray or or putty shades. You had actually pretty much every shade you could make a composite out of. For the most part, you could turn into a resin cement. The downsides, of course, was that even though you could bond to other materials and teeth, every material requires some sort of preparation through use of a primer, multi-step etching priming, silanating priming. Every single material, metal priming, everything requires some sort of primer to achieve. I remember doing the tin plating certain gold to get that to get some sort of bond to gold. So it definitely, while it had some promise, it was certainly technique sensitive. Now, why would you have to bond these things? Well, unlike some of the other, the soluble ones tended to be very dimensionally stable, if not maybe expand slightly. Resin, as we know, has a known shrinkage rate. And that shrinkage does cause, on an unbonded surface, some gap formation. I mean, I don't think that's a very controversial statement. In fact, if you don't use a bonding agent, it's highly likely the crown will just fall right off. So the priming of the various substrates was not optional. The other downside, like there are different types of resin cements, but not getting into, let's say, the purely light cured ones, the veneer type cements, but the dual cure or self cure resin cements. Timing of the cleanup was not simple. I recall, and there are other processing issues such as air barrier coatings, et cetera, et cetera. Not to say that has totally become obsolete, but just I remember it being very technique sensitive. If you had any subgingival margins, just etching it alone would result in copious bleeding that was very hard to stop. Then those questions, if blood got on it, how much did you have to re-etch? How long did you have to re-etch? A lot of, and we may not know all the answers to all these questions, but at the time it was, let's say a 10-minute cementation job for a single unit crown with resin modified glass ionomer could turn into a 45-minute ordeal, let's say in a second molar region where a deeper margin of the distal is inevitable. But another factor was the cement removal. So oftentimes, if you didn't time the cleanup correctly, the cement would get so hard that no amount of use of the explorer tip or even a scaler would remove the cement. And now I don't know, depending on the age of the listeners here, we had various saws and diamond strips and end cutting saws, and which funny thing, I still stock most of those for the rare occasions that we need them. But the removal of the cement was no joke. Sometimes it was not possible to remove without using some sort of rotary instrumentation. That's how crazy it could get. So difficulty in cement removal is certainly a disadvantage of the early resin cements. Time consumption, as just as a natural outflow of all this other time being spent. So a delivery appointment might take almost as long as a preparation appointment, depending on what you're doing. And of course, there was no fluoride release or any other benefits in that regard. Now, I threw in here as a 6th generation only because self-adhesive resin cements have been around for some time. I believe the first ones came mid-2000s. I still remember, I believe Kerr's Maxim may have been one of the first ones. However, I recall a lot of those crowns debonding. And of course, no, I don't know if times have just changed, but back then, nobody would take accountability. And I'm just picking on them, but they're only one of several, only because that's the brand I use. Oddly enough, if you prime the tooth, it would never debond, but then you're back to just regular resin cementation. So in the early era of the self-adhesive resin cements, I would have to say, unless you had excellent retention form, no short preps, no tapered preps. Just in case, we would put little boxes and lugs here and there to add more anti-rotational features and more surface area. Only because these self-adhesive resin cements, in hindsight, now that it's easy to armchair quarterback, but the chemistry just wasn't there. It did do some bonding to teeth, no doubt, but for example, to prepped enamel, no problem. Etched enamel, even better. Prep dentin, and we saw the results of that, a lot of debonded crowns. So, and a lot of leakage, a lot of micro leakage. When those crowns came off, you can quite see the effect of that. So with the self-adhesive resin cements, I put them in there kind of, maybe it should be a 5B generation, but either way, they're excellent in their resin form if you prime stuff. But in terms of, and when it says self-adhesive, that meant self-adhesive to tooth structure. It did not mean self-adhesive to other materials without priming. So even if you had in those days composite inlays, onlays, and even composite bridges were kind of popular, and they really still required silination and priming preparation. So really, when we say self-adhesive resin cements, I put them in their own kind of category because they did require priming of all substrates. However, you did have all the benefits that you have with other resin cements: color, translucency options, low or no solubility, one set, strong mechanical properties. In that sense, it wasn't really an improvement. The difference was really the fact that it could adhere to tooth structure, at least on the bench. In vitro, with excellent quality. In vivo, my experience was a little different. Now, the disadvantages, I think I covered for the most part, the need that we still needed to use primers on all substrates and often on the tooth itself. Now, here's a summary of all those generations from zinc phosphate all the way through resin cement. This is also from Godsey et al.'s paper. Here at the top row, and you'll see this replicated in many whether it's studies or textbook chapters, but that top row is this kind of ideal cement properties: high compressive strength, which pretty much they all achieve, at least enough to, I would say, chew ice cubes and popcorn kernels without any real fear. Compressive strength, I think, has been met. The tensile strength's a little bit different. Now, obviously, if you meet or exceed, and keep in mind, these numbers are fairly arbitrary. My eyes were opened as I started spending more time and doing more work for BISCO, exactly what these numbers are. So it's hard to really put a real value to them other than to say, view them relative to other numbers in the same category. The tests themselves are, I would argue, hardly meaningful in regards to a clinical situation. But certainly going from, let's say, a tensile strength of 6 from zinc phosphate to 10 in zinc polycarboxylate is meaningful and significant. Going from 10 to 18 for a resin, or a 6.5 to 18.5 from glass ionomer to resin modified glass ionomer is certainly clinically significant. And doubling that, essentially going from a resin modified glass ionomer to a resin cement to 35, 36 is, I think, at a point where no longer are you just breaking off, let's say, debonding, let's say, kind of failures. You're seeing failures that involve the material itself or even the tooth structure, like a fresh fracture somewhere else on the tooth other than the bond. So I would say resin cements represent close to meeting the goals of the ideal cement. Setting times are a little variable. Obviously, each one's depend on each manufacturer and what they're aiming to do with their cement. Working time also totally depends. Tooth structure bonding. I think at this point, it says resin cement is micromechanical, but that is without a primer. With the primer, depending on the chemistry of the primer, you can have both a chemical and a micromechanical bond. We have the fluoride release, which is debatable how important that is, but obviously many of us would prefer to have it in a margin, not a prosthetic margin. But resin cements did not have that compared to the glass ionomer, the 2 generations of glass ionomer. Pulpal irritation, it says high, but that's in direct contact. So you're always using it with a primer against tooth structure of some sort. And so I would argue that may be unfair in terms of high. And the solubility very low to non-existent. But that takes us then to next generation self-adhesive resin cements. Now, you'll notice the list on the left is essentially the same as the resin cements. However, the first category that I identified, this high adhesion to tooth and most restorative materials with little to no use of primers, is a significant departure. For example, bonding to zirconia does not require a primer. You can certainly use one. In fact, I do, but for different reasons. If you were to take a freshly milled zirconia processed zirconia crown, with or without sandblasting, and put next generation self-adhesive resin cement into it, it would most certainly bond to it chemically. It'll do better with a little bit of preparation, but it will bond. To metals, it most certainly will bond with no primer, with no separate primer. Porcelain is the one group. The porcelains, the feldspathic, the lithium disilicate class, those do still require the use of silination if you want a chemical bond. And there is one brand on the market, though it had to be reformulated, that does claim to be able to do both silinating and bonding at the same time. But let's wait to see what the real world use shows us. Other aspects are the high radiopacity. I believe that began somewhere in the early to mid 2000s. And I believe most cements, resin or otherwise, now have that feature. The fluoride release, now that's new. But fluoride release is maybe not all of them. I believe there's one or two manufacturers that do not, but I believe the majority now include fluoride release as part of their marketing or their claim feature. And there's other claim features depending on the manufacturer. The disadvantages, as far as I can tell currently, are limited selection of color and translucency options, but I believe manufacturers are working very diligent to increase their mix and over what's available. Theracem is one type of next generation resin cement, and it's dual cured, as most of them are, so it means light or self, although it is best to light cure even dual cured cement. That's just to basically to deactivate or use up the camphorquinone, which will help with any yellowing issues. But it also will help you maximize the strength of the material. So self-cure will work, light cure will work, but adding the light cure even to some degree will be is ideal. But Theracem also releases a calcium fluoride. We cannot claim anything other than the fact that it does release calcium fluoride. It is a self-adhesive resin cement suitable for eluting pretty much everything. And this whole generation, what it is, there is a chemical, which we'll talk about in a minute, which allows for most of this self-adhesion with little or no priming. Now, another unique feature of Theracem is that it transitions from acidic to alkaline in a few minutes, and we saw that way back with remember the zinc polycarboxylates. But that has a nice after effect for several reasons. One, a high pH will help to create even greater salting, if you will, at that junction. So your own minerals will help to further pack into any voids. But also, high pH does have a inherent antimicrobial feature to it. Next, we have the easy cleanup, which a huge departure from the early resin cements. Now, if you let it fully cure, or if you sit there and fully cure it with a light, well, yeah, you're going to have the same problems as you did with regular resin cements. But there is a kind of gel phase that these go through, either initiated with a tack cure, which I'll describe in momentarily, or with just by timing it, it does dramatically improve the cleanup speed and quality, I might add. High degree of conversion, that just means more of the monomers and free radicals or whatnot go through a chemical reaction, so they so you can better approach the manufacturer's numbers. Obviously, the high radio opacity, the dual mix feature, which saves chair time and helps to meter it properly, and of course the strong bond strengths with a minimal to no priming. That takes us to this interesting long name for this molecule, 10-methacryl oil oxyl decyl dihydrogen phosphate, or MDP. So this functional monomer was first synthesized in 1981. It first hit the market in, I believe, the form of Curare's Panavia kind of line of products. But what was its interesting feature is this long hydrocarbon chain, this 10-carbon chain there, which was very hydrophobic. And that wasn't fully appreciated till more research was done later by others, which showed that this hydrophobicity helped to prevent hydrolysis of the bond between two structure and the adhesive. The consequence of that, preventing this hydrolysis, is that the bond is durable and strong, at least to two structure. It also bonds to collagen, so I noticed that early on too. When you used a little too much MDP containing adhesive on the soft tissue sometimes, and then somehow float a little composite on there, often it was very difficult to remove. I found that interesting. And of course, it's the MDP's feature, a key feature, selling point, which is that it bonds to all the dental metals, and the timing of it couldn't have been better. It's tenacious bond to zirconia. So MDP has several chemical features that have a direct clinical benefit. The first I mentioned was this I didn't mention, but on one end of that molecule, you have this hydrophilic acidic functional group, that like phosphate type, which you'll see here on the lower right of that screen, the phosphate group there. And what that does is it starts out at a low pH, which gives you self-etching ability on contact. Now, the dwell time is important. Some people argue not just the dwell time, but also like mechanically scrubbing it in. I can't comment on that other than to say with and without, I've had excellent results. Now, one key difference is that has been shown though is etched versus unetched enamel. Prepared enamel is fine, but unprepared enamel, you'll see a dramatic improvement in bond strength if you etch the enamel prior to using MDP, exposing it to MDP. The MDP calcium salts that are formed between the two structure and the adhesives, or the adhesive, has low solubility, which, as I mentioned earlier, helps to have high initial bond strength that are resistant to breakdown. This long carbon hydrophobic chain minimizes hydrolysis, so you don't have like suddenly whole fillings falling out. You don't have crowns just falling off for no reason. It's super stable due to the hydrophobic aspect of it. And of course, the high bond strengths to metal, I think, are exhibited in its tenacious grip, nowadays anyway, most popularly to zirconia, but all metals as well. In Carrillo's et al.'s paper, which was another systematic review regarding the characteristics of MDP containing adhesives and cements, it was very fascinating because they did mention in a key paragraph, one statement that jumped out at me was, however, adhesion differentials between commercial adhesive systems are noticed depending both on the dental substrate and other components included in the adhesives formulations. So it's not just MDP. That's the translation there. It's the ratios and the mixtures of other factors. He continues, some universal adhesives were found to produce poor adhesive interfaces by being less 10 MDP concentrated, which suggests that an optimal concentration and purity of 10 MDP in self-etch and universal adhesives may exist, so the maximum potential of this functional monomer is achieved. And of course, I added that emphasis. Now, what does that mean? That means that MDP in and of itself, it requires some playing with the ratios. And we can kind of see that exhibited in this chart here that shows the self-adhesive cement or the next generation self-adhesive cement shear bond strengths to zirconia in light cure mode and self-cured mode. So you'll see that even though all of these products contain MDP, they don't all have the same bond strength to zirconia. And that's through a combination of enhanced bonds due to, again, messing with the ratios and optimizing them, as well as perhaps an inhibitory effect in certain situations. We also see that these next generation self-adhesive cement shear bond strengths to other materials, and here we have a comparison between Viscose Therasum and 3M's Reliax Unisum 2. You can also see that there is a difference on the same materials, but with slightly different recipes in terms of what is in the formulation of these and chemistries of these different cements. But both are excellent. That I might add. Both are far and beyond what we were ever getting with glass ionomer or resin modified glass ionomer. So we're going to briefly talk about how to use these to get optimal results. The first is you need a very clean surface. So sandblasting does achieve that to some degree, but you can't really see where you sandblasted. Now, there's some controversy what angulation, but frankly, the lab should have sandblasted for you since most dentists don't have their own sandblaster. And there's a proper way to do that, but I won't belabor that point. Steam cleaning only if you use some oil-based products during try-in or to mark high spots, etc., is vital. But you can also achieve kind of similar properties just by running a diamond burr over the surface immediately before applying any MDP-containing primer or cement. So for zirconia, my preference is after it arrives clean from the lab, we'll immediately apply MDP primer. I use Viscose Z Prime to achieve this, and there's plenty of them out there. But I put it on there and wait 5 minutes, and that's from internal data, the waiting of the 5 minutes part. But at this point, the reason I do that is because I don't like to put it on again. I don't like to clean it again because my chair time is very valuable to me. So my assistants will pre-prime it with a Z Prime, maybe hours in advance. It doesn't really matter as long as you do it at least 5 minutes before the patient shows up. Then we'll take off the temporary, clean up the preparation. I use ultrasonics to accomplish that, and then we'll try in the let's say the full zirconia crown. Now it's been exposed to saliva, but I already have MDP protecting my zirconia surface. Remember that phosphate group, that functionally active portion of that monomer, that's the part that will stick to the zirconia. And the reason why saliva, we want to prevent that, or you can't prevent it, but you're going to clean up because of those same or similar phosphate groups. So if it's already occupied by MDP, well, there's no room for saliva to occupy those same spots. So I like to put it on first. That way, after I do a try-in, then I just wash and dry my crown and proceed with the placing the cement in place, or the Theracim in place, or the Now, other people like to try it in first without priming, and that's perfectly acceptable. You can do so. But if you do that, now saliva has contaminated the zirconia, so you will not get you'll get a significant reduction in bond strength to the zirconia. So you have several options for refreshing that. You can either sandblast and wash and clean and go through all that process again. If you're really in a hurry, you can just, again, kiss the surface, the integrity of the crown with your high speed with a diamond in it. That works. Or if you don't want to change anything, especially on a thin restoration or one with thin margins, then you're going to have to use a high pH cleaning agent, which we have a few pictures of, and there's several available. I know one of the most popular is Ivoclean, I believe, by Ivoclar. I use Viscose Zirclean, which is essentially very similar chemistry. It's basically just a high pH gel. And once that is placed and you rinse it back off, now you're back to having bondable zirconia. For porcelain or lithium disilica materials, at this point anyway, it's advisable to prepare them ahead of time. silanating with or without porcelain etchant. I do everything, by the way. I porcelain etch, then I silanate. I do everything. But silanating, if you want the chemical bond, silanating is mandatory. After the surface has been cleaned and after it's been loaded, the intaglio has been loaded with the next gen cement, then the restoration is fully seated. I like to hold the restoration in place. Ever since we got rid of bevels on our preparations, I find that the restoration, it does fit, it is stable, but I find you can rotate it or wobble it just a fraction, a degree or two. Well, that degree or two can cause problems, either open contacts, high spots in your occlusion, whatever. So I like to physically hold it in place while my assistant or with my free hand, I will tack usually the buccal surface for about 3 seconds. Then I'll let go and tack the opposing side and then begin cleanup. After cleanup, I left that part out there, depending how long the cleanup takes. If it takes more than a minute, which it hardly does, and I'll cure it one more time for like maybe 20 seconds. And then continue on to do my occlusal adjustments as necessary. So here's just a diagram of the general workflow in terms of what you're going to put where. So in a porcelain or lithium disilicate situation, you're going to, they left the etching part out of there, but you can etch it first. The porcelain primer is basically silane. You leave that on according to manufacturer's instructions, and then you proceed, try and clean, rinsing and drying, etc. Then you can put the Theracem. For metals, zirconia, and composites, you can also silanate composites, but it's somewhat optional depending on what you're trying to achieve. But after trying, you can do the zirconia cleaning agent before the Theracem, or you can do the method which I do, pre-prime with an MDP containing zirconia primer, the crown, then do the try-in, then you rinse, and then you deliver with a next-gen resin cement. So here's areas where I personally find the next-generation cements to be particularly useful. First is the preps with deep margins. I'm not talking equigingival, 1/4 millimeter subgingival. I'm talking significantly subgingival. Sometimes I'll have patients who have very, very dry mouth, or people who are people who have had issues with their saliva glands or are going to undergo some sort of chemo or radiation therapy. In these patients, I like to make sure that we keep the margins in an area that they're not going to get recurrent caries. Dark preparations, and that totally depends on which manufacturer's cement you use. The one I use so happens to be fairly opaque, and so I like to use it kind of as a side benefit to mask dark preps. Difficult to reach teeth. Sometimes you just can't do an adequate job with the isolation or just even cleanup or whatnot, and so sometimes using something a little stronger with a little less technique sensitivity is preferable. Bridge abutments. This is a big one. On a 3-4 unit bridge with 2 abutments, it certainly is a bad day when one of those abutments debonds and you're left with the other one fully stuck on perfectly good and there's no way you can get it apart, and you're forced to redo the whole bridge. Well, I find in those cases, I will prime the teeth, just so you know. It's not just the next gen resin cement I'm going to use. I'm also going to prime the teeth. I don't care what type of preps I have. I just found that I sleep better knowing that this thing's never coming apart. Cementing fiber and metal posts. This is kind of a change for me, but I've been using these next-gen cements with an endo tip to cement my posts without any primer, just after cleanup. And the workflow to me is actually saved minutes off of my workflow. And in my practice, every minute is $10, at least. So we got to keep moving. So every minute I save is money saved. And for short preps, vital, of course, priming the tooth first. Preps where you've over tapered. Of course, I'll prime those first as well, or cut a box or lug into there, a groove. Some sort of anti-rotational feature. In terms of preps with chamfer or butt margins, certainly I prefer resin cement over all else, just because of to minimize any abrasion from the nylon bristles of one's toothbrush. And of course, patients with high caries index And that's only with the next gen fluoride releasing, calcium releasing type of products. Okay, so let's look at some of these cases. We'll start with some very straightforward monolithic zirconia crowns. It's funny, I just look at these today and it just makes me chuckle because when I started, I remember putting little like stained ochre. I didn't know what ochre was, but the ochre stains I put in the grooves, and I remember a patient telling me, what's this brown spot in this tooth? So it's just funny now. I'm seeing everything looks so average, but the patients seem happy. In any case, there's these monolithic crowns. There's a slight, like a satin gloss that results after you prime it. So we went ahead and primed them first. Then we do the try-in. Here are the dark, deep margin preps. And not all the margins are deep. I prefer to leave like the palatal or lingual margins equigingival if possible. That creates a little vent site for cement when you deliver it. They'll tend to blob up on that site that is equigingival. Plus the future soft tissue recession on the lingual seems to be a lot slower than on the buccal in most patients. Here it is, tack cured, 3 seconds. I will say when you're cementing more than one with any resin cement, but especially a dual cure resin cement, you do have to hurry. I do not take your time. Assume that everything's going to start, your working time's less than 1 minute. We turn all the overhead lights off, headlamps off, unless you're going to use a filter, because we have had instances when the second one didn't go on all the way but cured, and we had to cut it off and do it over again. Here it is after cleanup. So this is same day. So a little bit of bleeding around the margins, but excellent results. Of course, cutting a groove into the restoration for hygiene purposes, the buccal. Here's another dark prep, endo tooth with a fiber post. Much thinner margins here. As you know, the deeper you go, it starts to taper, and we have thinner margins, so they're not true. They're very minimal chamfer margins, very deep on the distal lingual, and then the distal high caries rate patient. And not only that, just salvaging that tooth. If you can see that core is, the margin of the core is at the margin of the tooth. Yeah, some of these teeth otherwise would be removed, but here we go. Very dark prep again. Theracem is loaded, seated, tack cured, cracked off. It literally breaks off in pieces, and then this I probably started cleaning up a little too soon. Now, sometimes just trying to get the photo, it does change our workflow, unfortunately. Here it is after cleanup. Here's the same kind of situation on a older case for a custom implant abutment. You can tell that weird satin finish. I'm not talking about the spit. If you look on the mesial surface of the abutment, it kind of has a weird sheen. That's the primer. Since we tried the crown in without priming the crown, go ahead and use a cleaner, rinse it off, dry it off, load it, and deliver, hold it in place, tack cure, let go, clean up. Pretty good. I mean, this is not an implant course, but how you design your abutments is very important to be able to minimize subgingival cement retention. Here's another case of tooth that basically fractured off. We're able to save it without a core, just prepping a little bit deeper, and you can see on the facial, just so we can get more mechanical form. But all these crowns you're seeing were held, the temp provisionals were held in with the zinc polycarboxylate, just so you know. And if you notice, there's no bleeding, there's no redness at the gingiva. It makes the next step of final cementation 10 times easier. Loading the crown with Theracem, in place, tack cure. And these deliveries don't take more than 5 to 10 minutes. Sometimes they do need to be anesthetized, depending how deep the preps were. Here's the zirconia primer I use. All of the modern ones that I'm aware of that bond to metal or to tooth structure or to anything else, I'm sorry, not tooth structure, metal, zirconia, etc., are MDP containing. So in this case, we're putting on our abutment. And if you can also put on the intaglio of that as well as in the screw channel if you want additional retention. The bridge itself, primed 5 minutes prior, of course, minimum. Provisional screw retained bridge is being removed. This patient has a class 3 occlusion. We won't go over the case too much. Platforms of the implants, the hybrid custom abutments are being delivered. Now, this brand did not have a CAD/CAM system, so these are made by hand. This was delivered, I want to say, in 2018 or 19. It's right when TheraSim came out. And I just saw that. I hadn't seen him all through COVID. I just literally saw this guy like a week or two ago. It still looks awesome, considering. Try-in. Since this was primed with the zirconia primer, now we're just rinsing and drying. That's all you got to do. As opposed to the whole, surface cleaner. Holding the bridge while my assistant tack cures. This is after cleanup. Here's another case. This is a fracture number 9. This one, we're doing a provisional Maryland bridge. Provisional removed. Okay, this is us using TheraSim to block out the gray of the titanium base on this hybrid abutment, another older case. Hybrid abutment in place, already pre-primed with zirconia primer. Screwed, torqued, obturated with basically plumber's tape, Teflon, final crown delivered. And that was it. Looks like we have question. Let's see here, 5 questions. Let's see here. Yes, I agree. Okay, so Octavio makes a statement that TheraSim is wonderful, but if it cures all the way, it is a nightmare to remove excess. And, I agree with you. That's why as I mentioned, with all resin cements, you cannot miss that. You have a small window of time if you're going to rely on self-cure that you got to clean it up. With light cure, when I say tack cure, I mean really just a tack cure. So if you got some like 2000 milliwatt light well, maybe 1 second is enough with that or less. Even though some people just use the overhead light, and that's usually enough. I like to tack cure. I use a 1500 milliwatt. I want to say Kerr makes it. I don't even know the name of the brand, but anyway, I just tack and wave, maybe one or 2 seconds, 3 seconds at most. I try to angle it from the occlusal proximal kind of line angle, if that makes any sense. In any case, you're going to have to play around with it a little bit, but you want it just past a slight doughy phase. So if you can peel it, it's too soft. It's going to crumble like you saw in one of those earlier pictures. If you wait till it's just to the point where it starts to get a little bit firm, it's a perfect time it just breaks clean. So, but just so you know, in fairness to TheraSim, this over curing is or fully curing is a problem for all resin cements. Okay, Peter says your thoughts on resin cement ZR Sem by Premier. Good cement for zirconia crowns of primary because it has MDP. I've never tried that cement by Premier. MDP, just having MDP will definitely be of some benefit in the sense that it will adhere. However, as you saw by that chart, optimizing the ratios of, and not just MDP, shockingly, just the amount of water or alcohol you add can result in dramatic differences in bond strengths to some of these substrates. So you, to some degree, have to do your own due diligence. And a lot of these manufacturers, I know at BISCO, you're welcome to ask questions directly to the scientists, and they'll be happy to point you to their publications or to internal data to justify an answer. So, no, good question. What's the best cement for implant crown? Wow, that's the $1 million question. Frankly, I use these next gen resin cements. I went through a whole decade of just resin modified glass ionomers, but there were some issues, and mainly it was the debonding, the predictability issue. I don't deliver implant crowns to retrieve them. If I plan on retrieving them, I will make them screw attained. So, that's kind of a trick question. So when I do use a permanent cement, I generally will use what you saw right there, Theracem for most of it, because I don't like to stock 10 different cements, So this literally replaces like 3 or 4 just in one tube. But when I go to deliver an implant, let's say it's like 8 or 9, and it has to be cement retained. Well, in that circumstance, what I'll do is all starts with the implant placement. And if you're not placing your own implants, that's understandable. But regardless, you want to have it such that it makes the angles optimal for restoration. But let's just say you're just stuck with an implant that's off axis. Well, you're going to have to re-angle that with your custom abutment. And in doing so, you want to design it such that at least one margin is equi or supragingival for 2 reasons. One, when you go to deliver the cement, the margin that is at or above the gum line, that's where the cement will vent out of naturally, just hydraulic forces. Number 2, though, you're going to visually and tactily with your Explorer be able to see that you have your restoration fully seated if the margin is at or above the gingiva. Just one of them. So I always do it on the lingual margin, lingual or palatal. The second thing I do is I make sure my buccal and mesiobuccal margins are 3/4 millimeters subgingival. And the reason for that is to hide any metal or any cement line, any junctional transition. I don't want anyone to see it. And the distofacial margin we'll put at like 0.5 millimeter. So that requires just designing it properly in your CAD/CAM software for your technician to do so. The third thing we do also precedes the actual delivery of the abutment, and that is using an appropriately sized and shaped healing abutment. Or provisional restoration, depending on your circumstance. And that's like half the battle, to be honest, just to get the proper or close to the proper shape before you even go to the next step. So hopefully that answers your question in that regard. But yeah, I just use a permanent cement. Granted, I am spoiled to have my own in-house lab, but I have not retrieved a cement retained crown. Many years between them. If it happens, it's because something broke or screw got loose or something like that. All right. What type of primer are you using for, this is John asking, what type of primer are you using for the tooth prep? I don't prime it. That's the whole point of these next gen cements. You don't have to prime the tooth. The primer is the MDP. It's in the cement itself. And it's not like the old days, the original, let's say Maxim, which it barely stuck. This is legitimate. The MDP has incredible bonding to the hydroxyapatite crystals of your dentin and enamel. So now let's say that you have unprepped enamel. I don't know what circumstance that would be. Let's just pretend you have some. In that case, you would want to etch that unprepped enamel. That's about the only thing. In terms of priming, let's say you have a short prep or that which has let's just say poor retention form, over tapered, short, or both. Or let's just say that half of it cracked off, something where you just need belt and suspenders. And that's a situation I would use an MDP containing universal adhesive. I don't like to re-etch the dentin because I don't like to sit there and measure how long and all that business. As long as I have a clean or freshly prepped or otherwise clean dentin surface, I'll immediately apply a universal primer or adhesive. In that case, of course, my preference is Bisco's All-Bond Universal. And only because I think it's very, very well optimized. But certainly Scotch Bond is good. There's so many good stuff out there right now. It's incredible. But I of course I have a bias, which I did disclose. I mean, I get to have a say in how these things are made. So always helps. Okay, do you need to have a dry feel before cementing those deep prep crowns? Need for retraction cord? Back in the day when I did resins, I still remember vowing never to do resin again because I did have one. It was like a veneer case with some crowns that one had like a deeper margin. I remember taking 30 minutes to get the bleeding to stop. And this was in the days of iron, was it iron chloride? I can't remember. It was before the aluminum chloride. So I didn't know back then, but back then, like 3 years later, all my margins turned black. So it like scarred me. So in terms of a dry field, yes, you do need you cannot be weeping, whether it's blood or crevicular fluid. So it needs to be dry enough. Having said that, there are not enough. I mean, let's put it this way: because, for example, the MDP comes in acidic, as long as you have. And by the way, let me take a step back. Some will even argue that the surface of the dentin ought to be a little moist. I'm not going to get into that argument here. I'm kind of old school, so I don't mind it being fairly dry. Not bone dry, of course, not desiccated, but it's got to be dry. But in any case, if you're worried, do a quick little mist of the prep and then blast it with air and put the crown out. You'll be fine. The contamination of saliva is not on the tooth prep side. It's on the zirconia side. So as long as your zirconia is primed and ready to go or otherwise cleaned before you load it, you'll be fine on that end. In fact, oftentimes when you see a debond against tooth, it's because you had other contaminants or the prep was non-retentive. So, but if you're worried about that you should prime in advance, then you can rinse and dry right before delivering the crown. But great question. What else do we have? Your thoughts on Ceramir for zirconia cementation? I have not used Ceramir enough to have a informed opinion of that, other than to say, if it's going to be a short prep or over taper prep, I don't see how that could be a good thing. Mainly because of the retention issue. I mean, the bond strength issues. So if you want a sure thing or a bridge prep, bridge is where you want to cry, because patient just paid you $5 to $10 grand. 3 years later, one of the abutments or two of the abutments are loose, and you can't get the third one off. Once that happens, these words will come back to haunt you, and you'll be like, okay, I should have just resined that in and never have to worry about it again. But in terms of Ceramir specifically, I can't make a legitimate comment. Cliff asks, if needed, what Bisco primer do you use for enamel dentin? Again, it doesn't have to be a Bisco primer. Any of the universal adhesives will do a great job when it comes to getting the chemical bond to a resin cement. Having said that, I do personally use Bisco's All Bond Universal. And so, but to be fair, at that caliber, at that level of manufacturer, they're pretty good. There's other if you're getting good results, I always tell people stick with what you're using. If you're getting frustrated, that's a time to maybe date around, if you will. Oh, and all right. And the last comment is just thank you. So with that, I appreciate your kind attention. If you have any other questions, like I mentioned earlier, it wasn't just a marketing plug. It's legitimately true. If you have questions regarding this or other chemistry type of questions, please follow up with the Bisco technical team, and they'll be happy to answer what they can. They're very free with their information, and you just got to reach out. All right. Thank you. Have a great evening.